Hey everyone, welcome back to Heart Health with Michelle. I am so excited to have Dr. Alon Gitig back on Heart Health with Michelle. He's a wealth of knowledge. I really admire all of his work and knowledge. So I look forward to speaking with you again. If you could just summarize a quick sentence about who you are, and we'll get right to it.
Sure. So in case anyone's joining us for the first time, I will just repeat what I said before. I've been looking forward to this. It's a real pleasure to do it. You are a wealth of information that I've been following on LinkedIn for a long time, and now on other social media venues. And I love how passionate you are about what you do. So thank you for having me on. I am Dr. Gitig, a non-invasive cardiologist for Mount Sinai. I work in Westchester, New York, Westchester County, in Scarsdale and Yonkers offices, where I am the director of cardiology, and I'm the medical director for the Heart Failure Alliance for the Mount Sinai Health Network practices.
Love it. Thank you so much for being here. So let's get to this information. So we know insulin resistance occurs in about at least 70% of individuals who have heart disease. We know inflammation is a key part to the promotion of plaque, but also for unstable plaque, which means that it can rupture and cause a blood clot, cause a cardiovascular event. So I want to inform our audience on what do these terms mean? But then also, when we look at the blood vessel, how do we kind of imagine what might be going on? Because it's very abstract. Heart disease is silent. We talked about coronary calcium scores. You don't feel it. You don't know that it's there until it causes a lot of blockage and you get that chest pain or that jaw pain, whatever it might be that causes that. So I just want to get into that information because I think it's really valuable to share.
Yeah, absolutely. So I'm glad we're talking about this topic. It's super important. When I trained in cardiology and began practicing 15 years ago, I knew a lot about cholesterol and blood pressure, how to check them, how to treat them. I thought I knew a lot. I've learned much more, but the fact is that was like very much my toolkit. Over time, starting around 10 years ago or so, I began to become extremely passionate and shift my practice to focus, at least in some part of my practice, more and more on prevention and trying to really understand how a healthy person goes on to develop artery problems and why even people who are on medications with well-controlled cholesterol and blood pressure often still end up with issues. And so that's where my eyes were open to how important these factors of insulin resistance and inflammation are. So I think the best thing to do is to first describe what you asked about last. So first describe what happens in the artery wall when somebody has a plaque buildup and a cardiovascular disease, and then to define insulin resistance and inflammation and talk about why they're important to that process. Does that work?
Perfect. Okay.
So every mammal has in their bloodstream these LDL particles floating around. And they are complexes of hundreds of molecules of cholesterol. And they also have hundreds of molecules of triglyceride in each one. So they're a cluster of cholesterol, triglycerides, something called phospholipids, all wrapped up into a ball with a protein. And we actually are not totally sure on why we need any of them floating around. We think it's because they need to deliver components of the triglycerides and the phospholipids to other parts of the body, which at times need it for their cell membrane repair, producing certain hormones, et cetera. But everyone has these floating around in the bloodstream, and the cholesterol is going along for the ride in those particles. In some people, in fact, in most people, if they live long enough, some of these, well, let me back up. In all people, these LDL particles at various points make it out of the bloodstream and they pass through the wall, the lining interface between the blood and the artery wall, and they get into the artery wall. So that happens a lot, and it happens in everyone, we think. And usually those particles kind of go through this mushy, soft structure of the connective tissue of the artery wall, and they pass into tiny little capillaries that are on the distal side of the wall, and they go back into the bloodstream. So they're just kind of waving to the artery as they harmlessly pass through. What happens in some people is that these LDL particles carrying cholesterol get trapped in the artery wall. They get connected to structural components of the wall, where they then are now stuck and will reside forever, probably. Once they're there, the lipid content, the cholesterol and the phospholipids, can become oxidized. That's a chemical reaction that changes the properties of those lipids and leads to plaque formation. Okay, so first step is the LDL particle gets in. Second step is it gets stuck. Third step is the lipid content gets chemically modified. What happens then is that certain type of white blood cell, which is a white blood cell is a soldier in our immune system, right? Called macrophages, or in their infant form, monocytes, come and they see this cholesterol that's been oxidized and they sense it's foreign. This is something that's different. I'm not used to seeing this. Now, if you're a macrophage, you're very good at your job. I'm a soldier in the immune system. If I see something foreign, I shoot and I ask questions later. I'm going to assume it's an enemy here to kill me. So the macrophage can't distinguish, is this oxidized cholesterol a bacteria, a COVID virus, or just something that is going to get stuck there and not do anything. So it engulfs it and it tries to break it down and destroy it. And what happens is more and more over time, these cholesterol particles that have become oxidized are getting engulfed by macrophages until they fill up with them and they become what are called foam cells. And when you have these cells that become essentially bags of cholesterol, that is plaque. Plaque is when there's lots and lots and lots of those that have gotten filled up. There are other things too. There are other cells that can sometimes pick up on chemical signals from the macrophages and come to the area and invade the plaque. Calcium can start to form within the plaque, but that's the way it starts. Now, when the cholesterol becomes oxidized, it's not just that it now is recognized as foreign by the macrophages, it also it is a pro-inflammation stimulus. So the oxidized cholesterol now actually can set off more alarm bells that makes the immune system rev up and send more white blood cells to this area because they think there's a battle waging that they need reinforcements for. So that's how plaque forms. Okay, so what is insulin resistance and what is inflammation and why is it relevant? Well, first I'll answer inflammation because we just talked about that. Inflammation is a word that gets thrown around a lot. And it's super important because more and more it's apparent that inflammation is a common link to most of the chronic diseases that kill or disable people in our society. What does it mean? When your immune system is activated, you have inflammation. Your immune system can be activated appropriately or inappropriately. If I get infected with the COVID virus, my immune system gets into high gear appropriately and sends lots of cells with their chemical bullets to shoot and kill the invader. If that infection is over and I'm recovered, the immune system is supposed to go back into surveillance mode and stop firing chemicals around and just look around, float through your body. The white blood cells go through your bloodstream and they look for invaders. But due to many factors in our lifestyles of the modern age, when you test with sensitive blood tests for inflammation, you find that many people's immune system stays elevated. The level of these test results are nowhere near as high as when you had COVID, but they are chronically higher than they should be. And that is associated with a significantly increased risk for cardiovascular disease. It may be linked to dementia risk, and it's certainly linked to risk for diabetes, maybe linked to risk for some cancers, but it's definitely a major risk factor for heart attack and stroke.
Yeah. And I think this is important to note because there's a lot of chronic conditions that have a low grade inflammatory component to it. And we often, and we see in the research, the connection and the links between them are very, very connected, but sometimes it's not mentioned, right? So when someone has fatty liver disease, or when they have uncontrolled blood sugar levels, or if they have high blood pressure, high cholesterol, a lot of times they also have underlying inflammation. And it's important that we don't look at these things in silos, but realize that there is a lot of connections between this, which is why the prevention piece is so strong, wrong because we can mitigate this low-grade inflammation through lifestyle intervention.
Yeah, it's a great point. And I'll say that the more I learn, the more I realize that basically it's safe to say everything's interconnected. So, if you have gout,
oh yeah,
you are at higher risk of heart disease. That used to be a mystery. Why is that? Well, now we know one of the reasons, not the only reason, is because of inflammation. If you have lupus, and now they know rheumatoid arthritis and ankylosing spondylitis and other inflammatory conditions, you have a higher risk of heart disease and stroke. Well, that's a big part of it. And the reasons are kind of obvious that's why I started with the explanation of what's happening in the artery wall, because I'm sure for people who are hearing it the first time, just like for many doctors also, and for me, when I started delving into this, it's not a big part of your training. It's hard to really wrap your mind around it until you sit and think about it. But essentially, the plaque is forming because your immune system, the white blood cell soldiers, are invading the artery wall. They're there and going in and out all the time, but now they're seeing something stuck there and they're fighting it. So the more inflammation in your body means your immune system is more activated, sending more cells out into all your tissues, including the vessel wall, and they're more fired up and discharging their ammunition. So obviously that's going to increase the risk, right? And so, by the way, we should say, it's so important. How do we know it's so important? Well, first of all, we have lots of studies that show the best blood test to find this level of inflammation, right? We're not talking about gout, where your big toe is red and swollen and painful. We're talking about inflammation you can't feel. Or you may be able to feel it, but you don't know that's what you're feeling, okay? It may be nonspecific fatigue, brain fog, et cetera, just not feeling right. But you don't have an obvious symptom. And if you do usual blood tests, the level of inflammation is below their cut point, so they're not going to detect it. Those usual blood tests only detect it if you have a pneumonia or a broken arm. So this is called high sensitivity C-reactive protein, or high sensitivity CRP, because the assay was developed to detect the differing levels of CRP level at a much smaller range and a much lower level. And if you're at the higher end of that range, that would still show up as normal on the regular, less sensitive test. You have higher levels of chronic inflammation and higher. So now we know they're above a certain cut point, you're at much higher risk for heart disease and stroke. And that when you factor in and do statistical adjustments for blood pressure and body weight and all that stuff, the risk is still higher with higher levels of CRP. Okay. So what caused? We also know that in studies where they've given statin medications for high cholesterol, and then after the fact, go back and look at the data and see what's what, that if they find people's CRP happen to go down, they were at lower risk. One of those studies was actually done in a way, it's called Jupiter, the Jupiter trial, where they said, we're going to test this inflammation hypothesis definitively, and we're going to only include people whose CRP is over 2.0. So we're going to include people who we know are at the higher end. You must have that to get into the trial. And then we're going to give some Crestor and some nothing. And the people who got the Crestor had a significantly lower statistical chance of having a problem. So in those studies, if your cholesterol went down with Crestor, you did better. But if your cholesterol went down and your CRP went down, you did remarkably better. So that's why we know this is important.
And that really ties into the beginning of the whole explanation, right? We know that there needs to be oxidation and there needs to be inflammation for that plaque to form. So we need to address inflammation, and we do that through many modalities, from eating, from our nutrition, our physical movement, our hydration, our sleep, our stress. We have to look at everything to help reduce that tremendously. I think that's awesome.
Yeah,
I know you have
all those things, by the way, because that's very important for people to understand. Every one of the things you just mentioned can be its own 1-hour talk on how to optimize it, and all of them contribute.
So I know we are almost on time. So I just want to ask, can you explain a little bit about insulin resistance in as short as we can do, so that people understand that connection, because we always talk about lipids, and I find that people always try to look at, oh, cut out carbs, cut out fat, cut out this, like no one's ever talking about the whole picture, and insulin resistance is super important.
So absolutely, and I'm okay. I have a few minutes left. We can definitely do this justice. So insulin resistance literally means your body produces insulin, and it means your body's tissues that respond to the insulin signal no longer do so normally. Now, the basic thing to understand here is you eat a food, usually a sugary food or a starchy food. It raises your level of glucose in your bloodstream once the food gets digested and absorbed by your GI tract. When the glucose level in your blood increases, even small amounts, your pancreas is very good at sensing that, and it makes more insulin to lower the glucose level. So we eat, glucose level goes up, pancreas makes insulin, brings the level down. How does it do that? The insulin levels don't magically just, demolish the glucose. The way it does it, for the most part, is the insulin binds to muscle cells, and when it binds to the receptors on those muscle cells, the muscles take up glucose from the bloodstream. Okay, so once again, basic construct: eat, glucose goes up, insulin gets made by the pancreas, binds to muscle, muscle sucks out glucose from the bloodstream. So insulin resistant. Now, insulin has actions on almost every other part of your body. It affects your liver, it affects tons of organs, fat tissue, et cetera. And those cells can also become resistant to it. But for the purposes of simplicity, and because it's the most common relevant understanding, we're going to focus on insulin resistance in the muscle. If your muscle stops reacting normally to the binding of glucose there, it doesn't take up glucose the way it used to. So now it will still take some up, but it'll do so less in response to that insulin binding. So you could understand why, if that's the case, the glucose is not going to go down as much, and you're going to be left with a higher level of glucose in your blood. So that's insulin resistance. Now, the tricky part is that you would think, well, if we just check our blood glucose levels, we're going to know if we're insulin resistant. And the answer to that is eventually that will be the case, but it takes about 10 years to find that out. And the reason for that is that when you're healthy and you don't have insulin resistance, your pancreas makes some insulin to get the glucose levels down, but it doesn't need to make that much. It has the capacity to make much more. When you start becoming insulin resistant, the pancreas is so sensitive that it sees the glucose does not come down quickly, and it may not fall as much after you eat something. So it just makes more insulin. If it doubles the output of insulin, so now you went from a few insulin molecules binding to receptors on the muscle cells. Now you just have a lot more bind to their receptors. Each muscle cell is not going to take up as much glucose from one insulin binding, but when you recruit a lot more muscle cells, you eventually get the glucose to stay at the same level. You get the total net uptake of glucose. So that process can go on for a while, where your pancreas keeps glucose in the blood normal by making a lot more insulin. And over that course of time, your blood test for glucose looks normal, but you have insulin resistance. And the only way you're going to know that is if you can monitor what your insulin has to do, what your levels become after you eat. And that's a test that's tougher to check. We can check fasting insulin levels, and when they're above 10, they give us a strong clue that someone's insulin resistant. But ultimately, the only way to know for sure is to do something called a glucose tolerance test, where we give people a very sugary drink and we check their insulin and glucose levels at various time intervals after they eat. So there are some other clues that that's going on, which you can ask for, things like seeing if your triglycerides are high, and especially if they're 3 times higher than your HDL cholesterol, your uric acid level, your liver enzyme called ALT. If that's starting to rise, that's a signal. But those are the ways you can know you have it. Now, it's important because 2 things. Can I add one thing? Please.
So waist circumference, right? So a lot of times we go on the scale, but if you have an increased waist circumference above, it depends your ethnicity, but generally above 40 inches for male, above 35 inches for female, that is a big indication. Or if you're trying to lose weight and it's really stubborn and it's not coming off very quickly, that can also be a sign of insulin resistance. And skin tags. Those are 3 things I would add, but definitely liver, a lot of
Couple
people don't.
others.
Yeah, so many.
You just reminded me, something called acanthosis nigricans, which is like a dark, velvety consistency of the skin on the back of your neck. Pretty much 100% means you have insulin resistance. The waist circumference, so critical that you mentioned it. Yes, those cutoffs you mentioned, 40 inches for a man and 35 for a woman, significantly increase heart disease risk. But if your waist circumference is expanding, you probably have insulin resistance, unless you're just very bloated and gassy. But why is that? So again, your blood sugar may be totally normal, but in the background, what's not being tested is that to keep it normal, your insulin levels are very high throughout the day whenever food comes in and raises and starts to spike your blood sugar. What does insulin do? Well, I said it has lots of effects on, I know you know this, but one of the things it does is it binds to fat cells and says, take up more energy and store it as fat. So if your insulin levels are high throughout the day, you will gain belly fat and you will not be able to lose it very easily. So yes, that's a critical clue. Blood pressure. Insulin has lots of effects, as does glucose, by the way. It's a double whammy if you're insulin resistant. When you eat and your glucose spikes, if that spike happens multiple times a day over many, many years, you can damage organs. You can get neuropathy, for instance. You can be at risk for heart disease. But the reason it's a double whammy is because every time your glucose spikes, you know that your pancreas is going to make more insulin and there's an insulin spike going on. And the insulin molecule itself has other damaging effects. It's not just the sugar. The insulin is a promoter of growth. It can promote extra cells depositing in the artery wall. It can promote plaque in the artery wall. It probably promotes changes that increase risk for dementia. And as a promoter of growth, if you start to be at risk for cancer, insulin is going to likely increase that risk. And many cancers are now linked to insulin resistance. So it's very, very important. Now, we explained the process of plaque formation in the artery wall. The insulin resistance state leads to changes that, first of all, make that process more likely to happen, make things more inflammatory. So the immune system is often revved up, your CRP level is often higher. More revved up immune system means more macrophages soldiering on in the artery wall. But also, it makes for a state where you're more likely to clot when you get a certain stimulus. And so now, if any of your plaque gets exposed and is at risk of causing a clot, the fire is just burning bright and you're much more likely to close off a vessel.
Right. I love it. This is so, so important. Insulin resistance, inflammation. We need to address both of them. We need to make sure that we are aware of them, but also adding in lifestyle, medical intervention to help reduce these factors so that we can keep you healthy and improve your cardiovascular health and prevent that atherosclerosis or that plaque formation to cause any damage. I love our conversation. Any one last tip you would give the audience before we wrap up?
Well, what I would first of all say to you is that, I think what we should think about doing, and I'd be happy to come back, is scheduling a call where we can actually tell people, well, what can you do about it, right? Because there are so many things, and that's why I love that you mentioned them before, having to do with nutrition, both guided to help you lose weight and belly fat, as well as specific types of foods that are inflammatory, as well as exercise, mind-body stuff, stress, sleep, et cetera. So dental, oral health, for inflammation, there's so many things. So maybe we can dedicate a future conversation just to that.
I would love it. I would love it so much. Thank you.
But what I would just say to leave people is know these facts and be proactive about it, because unless you specifically ask your doctor, are you checking me for insulin resistance? And if so, how? And inflammation, do I need any imaging of my arteries to look if I'm at risk? A lot of the times these things are just going to get breezed by because we live in a very fast-paced world in modern medicine.
I love it. So important. Take ownership of your health, ask questions, and be empowered to take action today to really reduce your risk of heart disease. Thank you so much, Dr. Gitig. This was amazing. I appreciate all your insight.
Thank you for having me. It's been a pleasure. Really fun.
Thanks.